Okay, Kat. So this week we will begin our study of various bodily systems, the diseases that they can um, experience and conditions that they can experience, and the drug therapies that may commonly be used to treat those. Now, it will necessarily leave out very uncommon or rarely used drugs for the simple reason that they're generally used only by specialists, and there are a lot of drugs anyway. So we will um, we will be talking about those things. So we, if we look at the readings and tools, um, you're going to be reading parts of chapters 12, 13, 14, and 15, and then chapter 18. So there are roughly 10 to 15 pages of reading for most of those. So uh, you should be reading those, get those chapters read through. So I'm going to go through those chapters. Now you see you've got a discussion post. I'll go to that in a minute. We have the assignment, which will work out the same way as the one in the one last week, which is you have workbook pages here that you can look at, um, and the all of the chapters from week 2 are here, so don't worry about it. And then you have the assessment to do. So let's try to keep this current just like you did last week. I was real pleased with the work you did last week. So let's go back to the week briefly. This week's discussion is about drug classifications, about drugs that are used in affecting diseases of the central nervous system. Why, the question is, why are many of these substances often abused? And what can pharmacists and pharmacy technicians watch for and do to help prevent abuse? So give this some thought. You may want to do a little research on the topic as well. But it ought to be it's something to think about, because CNS drugs often are included as scheduled substances. First, the anxiolytics like Librium and Valium and so forth are controlled substances. Um, Drugs for treating ADHD are almost always Schedule 2. So there are a lot of these things to think about. And you might ask yourself, why do these conditions end up with people becoming dependent and abusing their drugs? So think about that in your discussion. Let's go here. The in-class activity, I'll find something that you'll be doing on Wednesday night. The week 2 assignment, we talked about the assessment is a typical assessment. You have no time limit, and you can attempt it 3 times to maximize your grades. So we will take it from there. So let's go back to looking at the chapter, the PowerPoints for the chapters. We'll start with chapter 12 as soon as it condescends to load. Chapter 12 is about the integumentary system, and you remember from your A&P classes that that's the skin and related systems. And there are many diseases. Practitioners in the field of integumentary diseases include, of course, dermatologists, some allergists, some cancer specialists also. So if we look at this, the integumentary system is what holds us in. There's an old line about respecting your skin because it's what holds us in. So we do try to take care of it. Unbroken skin has a number of different protective issues, including it being one of a part of our innate immune system, which basically it's a barrier. It's a physical barrier to attack by infectious organisms. The skin is vital for all other organs to function. Among other things, it breathes. It also allows the body to cool itself through perspiration. It is the largest organ of our body. So many of our common diseases involve fungal or bacterial infections. There are inflammatory diseases and, of course, traumatic injury. The integumentary system includes the skin and the other structures that are a part of the outer barrier of our bodies: nails, hair, sweat glands, the glands that produce cerumen, and the sebaceous glands. The skin is a self-repairing organ. In the absence of something preventing that from happening, the skin will repair itself in terms of small cuts and rips and burns and other injuries. So the skin is designed to take a lot of abuse and recover from it. The outer layer, of course, is the epidermis. The inner layer is the dermis, and then there is the subcutaneous layer below the dermis, which binds it to the underlying organs. And here we'll include things like muscles as an organ, because, of course, our skin is over our muscular structure, which is outside the skeleton. So here is a good graphic of skin layers. We have the epidermis, which is a very thin layer at the top. The dermis, which contains the bodies of various glands, like sweat glands and so forth. It contains blood vessels, both arteries and veins, supplying nutrients to the skin itself and to the hair. The hair follicles, the shaft goes in. You remember this from your A&P class, down to the root of the hair, where we have a blood supply and a nervous supply that goes to that. Nerve fibers circulate through this part. These nerve fibers are of two types. One senses pain, and the other senses pressure. And the pressure sensation can overcome pain, which is why if we hurt ourselves and we push on it, it stops hurting. We've overcome completely the sensation of the pain with the sensation of pressure. So we have a little bit more detail here. The epidermis does not contain blood vessels. The epidermal layers from the deepest to the most superficial include the stratum basale, or the stratum germinativum, contain the melanocytes, which give our skin some pigment. The stratum spinosum contains the keratinocytes, which are filled with a protein-like substance known as keratin. The epidermis, one layer, the stratum granulosum, is where keratinization begins. The stratum lucidum is only in the palms and soles, palms of the hands and the soles of the feet, um, and contains, it is specially structured to allow for both sensation and for function. The stratum corneum is the most superficial and it's mostly dead cells. We slough off cells very rapidly. The dermis um, contains just about everything else that we need. It contains collagen fibers, elastin fibers. Elastin is a protein that that stretches and coils and so forth and allows things to move without tearing. Blood and lymph vessels, nerves, and some smooth muscle, hair follicles, and the sweat and sebaceous glands. Accessory structures include hairs and nails. Hairs have their own anatomy. Um, the Okay, they have their own anatomy um, with that is a follicle, a root, and a shaft. The hair shafts are the things that we see on the outside of our skin. Um, Nails are hardened keratin and consist of the root and the body and the edge. So if we look at hair, we've got a lot of things here, a lot of structures. I won't go into these in any detail. You can certainly pause this and study this a little bit more or study it in the text. But we have the hair shaft comes out of the root sheath and the root of the hair, and the root is where we get oxygen exchange through the artery and veins that are associated with each of these hair shafts. So the shaft that we see comes out of the skin. It has a structure, a substructure as well. The structure of the nail, we have the nail, the lunula, and the cuticle, also known as the eponychium. So, and then the free edge is the part that extends. It is not attached to any other structure. So it's the part that is that we see sticking out from the skin. Sebaceous glands produce sebum. Sebum lubricates the skin and makes the hair shiny. It is analogous to lanolin, actually. Sweat glands are found in almost almost all body areas. They're most numerous on the palms and the soles because those are exposed areas that need to evaporate quickly. Sweat is similar to blood, but it is without the cells. Functions: protection. This is our first line of protection against pathogens and for retaining water and protects us and protects us from ultraviolet sunlight. Our sensations, we can detect. We have dermal receptors that can detect pain, pressure, heat, and cold. Sweat glands lubricate hair and skin, and they're involved in the manufacture of vitamin D from sun exposure. And it's involved in thermoregulation, meaning helping us maintain a pretty much constant temperature, no matter what our conditions are. So disorders are ulcers. Ulcers in the skin are things, you've probably seen them where you work. Decubitus ulcers, bed sores are there. Fissures are just breaks, cuts. Macules and papules and pustules and vesicles and nodules are swelling containing different materials. We have dermatitis. Remember, itis is inflammation, so dermatitis is an inflammation of the skin. Atopic dermatitis is an inherited um, characteristic is an inherited reaction that is characteristic of allergy. Rashes, when we have an atopic dermatitis like eczema, the rash occurs on the face, neck, elbows, knees, and upper trunk. Um, the treatments include topical treatments, creams and ointments, and a lot of times with cortisone or other steroids. So this is what a dermatitis looks like on the back of a shoulder, this reddening. Seborrheic dermatitis is characterized by itchy, erythemic, just means red, and oily skin patches, and often dandruff-like scales. Large ones are shed. We see this a fair bit in infancy. We call it cradle cap. Um, we we should be looking at low strength cortisone or hydrocortisone creams for it. So this is sort of what that looks like. Take a look at this baby and see what's being shed here. Contact dermatitis is something that's typically involves things that we touch and react to. Poison ivy, poison oak, etc., are the most common of the contact dermatitis causing substances, but other things can do it. And we can be actually physically allergic to a variety of substances besides those. So contact dermatitis, you can see these swellings and what look like blisters. Psoriasis is actually now is thought to be as much an autoimmune disease as anything else, but it is an inflammation where we get raised red patches and scales, silvery scales that look like they're just white flakes on our skin. That's been linked to a number of different things. Treatments include a number of approaches, including ultraviolet light, to try to stimulate some skin health. Topical creams and ointments, vitamin A, antihistamine, and oatmeal baths are an interesting topic here. But this is what a very severe psoriatic lesion looks like. This patchy white mess here. It's quite. It can also be quite painful. Acne vulgaris is common acne. We can treat it with a few things. Mostly affects adolescents at puberty, and severe cases or persistent scratching and trying to pop the lesions, the little infectious spots can often lead to skin scarring. We can use antibiotics, vitamin A, and other agents for treating these things. And this is what it looks like because of the scarring. When the scarring occurs, scars often pucker the skin. And so when these scars occur, you get this unattractive puckering of the skin on the face and perhaps even other parts of the body. Herpes zoster is shingles. Herpes zoster is one of the multitude of herpes family viruses that can infect skin and other organs. Zoster occurs along peripheral nerves. It can cause intense pain. It can cause fever. Vesicles are just fluid-filled bubbles, so like blisters and macules and papules and other things. It's the same virus that causes chicken pox. Usually, it happens later in life. Chicken pox is considered a um, is considered a um, is considered a childhood disease. Sorry, I just sort of blanked on that. Most of the time, we try to use the drugs, anti-inflammatory agents, steroids, sometimes, and pain drugs, and even sometimes some of the minor tranquilizers. This is not the right name. It's Zostavax. Zovirax is actually acyclovir, which is an oral antiherpetic agent. So here we have a very bad case of shingles. You can see here on this guy, these blisters here, these macules and papules, and this is probably pretty painful. Cellulitis is a bacterial infection of the subcutaneous tissue um, that usually happens because of a traumatic injury of some sort. It can be caused by either staphylococci or streptococci, families of bacteria. And we can use antibiotics, analgesics, and in severe cases, we may have to really immobilize and elevate whatever the affected body part is. And it can be almost anywhere on the body. Here is an example of cellulitis, this reddening and quite clearly swelling of the skin. And here we have a bit of focal infection. Here we have something more diffuse. All of these are indicative of that. Untreated, this can be very serious. Impetigo is a bacterial infection, usually in children. The problem is that it is very, very contagious. So if a child goes to school with impetigo or just developing impetigo, it is likely that that child's classmates are going to get infected. Um, these are blisters. If we can, here we can see impetigo. They form blisters. They crust over. The children scratch them. They and burst these things and leave this margin. So we use antibiotics and regular cleaning to try and treat this. But it is something to not to be cavalier about. Dermatophytosis is a fungal skin infection, also known as tinea or ringworm. Scale-like lesions, again, with raised itchy edge, may be on body area, may be called athlete's foot, jock itch, tinea capitis, or tinea corporis. It depends on where it occurs. Okay, tinea capitis is obviously in the head. Tinea corporis is the body. Jock itch is the genital area, and athlete's foot is the feet. Generally, we're going to use topical and sometimes oral antifungals. We can get those OTC or by prescription if we have a really serious event. So this is what athlete's foot looks like. This isn't a great picture, but if you look right here, you see where the skin is changing and peeling off, and we can see here a lesion on the foot, and where we have discoloration here on the heel and the pads of the toes. Tinea capitis is in the head, and we see this manifestation here, this flaking and clear something not right. Tinea corporis on the body, again, it's a fungal infection, so you're going to see discolorations and flaking of skin. Moles are very common. A lot of people have them. I'd say probably most people have moles. They're usually benign. Um, they're produced by just melanocytes, dark cells. Um, uh, further darkening and enlargement as we age may, and I want to emphasize, may indicate skin cancer. It should be examined. But generally speaking, you don't worry about treating them unless they get chronically irritated. Sometimes, if they're in an area of the body that is constantly being rubbed by clothing, such as the belt line or perhaps around the neck, they might get irritated and they might need um, a a treatment. Oh, and there are several. Surgery is not the only thing. We use a process called cold burn, which uses liquid nitrogen to burn and kill the cells that are involved. Verruca vulgaris is a wart. It is caused by the human papillomavirus, one of which, let me emphasize, there are nearly 100 human papillomaviruses. One of those has been linked to cervical cancer, and there is a vaccine for it, which is used to try and protect young women against cervical cancer. Transmission is direct contact, and these warts can sometimes be removed by topical applications. One of the things that you can do is actually make a skin plaster um, of aspirin and just put it on there, and that will actually that will actually clear some of it. There are several other preparations that can be used. Severe cases may require surgery, especially if we're talking about plantar warts at the bottom of your foot, which make it impossible for you to walk. Vitiligo is something that is just irregular patches of skin that don't have the pigmentation. This is not generally considered a critical disease. It is, however, a disease that is not very pleasant. Burns is another serious issue. It's something that we can get from a lot of different sources. Burns are a family of potential injuries. It can be fire, it can be sunburn, UV radiation, very hot water, spills of chemicals, radiation, and strong acids and bases. There are toxins that will produce burn-like um, conditions, excessive heat, electrical shocks. Um, the burns are actually a leading cause of accidental death, and we have 3 different types. Old language was 1st degree, 2nd degree, and 3rd degree burns. 1st degree means just basically you scorch yourself, maybe quickly with a match or something, and it hurts. It might swell a little bit, and it might turn red, but it usually resolves within a day or so. 2nd degree actually involves both the dermis and the epidermis, and it can produce blisters and um, and various discolorations, and may leave scars. 3rd degree burns totally destroy epidermis, dermis, and deeper tissues. Repair of those is often difficult and requires surgery and skin grafts. and they are a lifelong event. We now call these things partial thickness and full thickness burns. Um, the difference between first and second degree, for instance, is often very difficult to judge, because when the heat goes in, the body doesn't dissipate it very well, and so it can stay there and move deeper if cooling isn't applied. That's one of the reasons we tell people put an ice cube on it, or put it in, or run it under cold water. So you have to look at that. We prefer partial thickness and full thickness language now to describe these. This is what a first degree burn is. This is a pretty nasty sunburn. Second degree burn, here you're starting to see the swelling, the edema here, the redness, and actually the tissue has now become permeable and is leaking fluid. Third degree burns, this is all the way down to into the adipose layer, and sometimes down to muscle and bone. Skin cancers are common in the United States. Here in Colorado, where we have a thin atmosphere, so we have a lot of exposure to cancer-causing radiation from the sun, which is why people suggest that you have a dermatological check regularly. The deadliest is malignant melanoma, and the more common are basal cell and squamous cell carcinomas. There are lots of ways we can deal with it. We start with surgical excision if necessary. I mentioned cold burn, that's cryosurgery. What we're doing is basically freezing the tissue and killing it. There is a way of using electricity to dry out. Curettage is just removal of scraping away the tissue that is um, abnormal. And we can also involve radiation therapy. The problem with malignant melanoma is it is one of the faster cancers to metastasize to other tissues. And so it's best to catch it early. A basal cell carcinoma, this looks sort of like, you know, the top of a volcano. You've got a ridge and a depression in between. This is, you can see, this runs from is about a centimeter, which is 4/10 of an inch in diameter. Squamous cell has puckers a lot more, and that's what we're seeing here in this particular patient. And then malignant melanoma, often is black, and so this the melanoma here on this man's face is pretty noticeable. Other diseases that many of us would consider fairly unimportant include baldness, alopecia, loss of hair, especially on the scalp. We have male pattern baldness. We have other forms of alopecia. Male pattern baldness is usually transmitted through the mother, and so it is a genetic disease. We have drugs to regrow hair. We can transplant hair. We've experimented with using patients' own skin tissue from areas that do have hair for growing hair. So this is an example of alopecia. This is the beginning of male pattern baldness, balding from the back forward. Nail disorders can be infectious. They can be uh, related to other problems, anemia. Um, so we can have paronychia is infection at the nail edges. Um, onychomycosis is is a fungal nail infection. Onychocryptosis is an ingrown toenail, and most of them include antifungal treatment, which can go on for many months, if not a year or more, and treatment of any underlying conditions that may be contributing to the unusual nail growth. Paronychia, right here, if we go back up here, it's an infection at the nail edge. Here's an infection site, and around here you can see the swelling and the shininess of the skin. Onychomycosis, this is, if we go back again and look at it, this is fungal. And it's characterized by this discoloration. And what happens is we treat these with drugs, and eventually healthy nail grows out. Onychocryptosis, the ingrown toenail. If you look here, you can see the entire toe is very much swollen around the nail. And there's discoloration at edges and other things. Okay, so drugs that we use to treat these integumentary system disorders include anesthetics, antifungals, antihistamines, antibacterial, antipyretics, in other words, anti-inflammatories, and corticosteroids. Okay, so that is chapter 13. And I'm going to stop here for a minute, take a breath, and pause the recording. So I'll come back on in a moment, and you won't miss me. Okay. So now let's go to chapter 13, where we're going to look at the musculoskeletal system. It's actually two systems, muscular and skeletal, including muscles, bones, joints, and various connective tissues. As the skeleton develops, we find that we deposit the solid portions of bone and replace cartilage and other things in the fetus. So the primary structures that influence the body movements are the skeletal muscles. Skeletal muscles are part of the voluntary muscular system, and they're the muscles we think about when we move, that we control, as opposed to those that happen automatically, the autonomic muscular systems. Nearly half the body's mass is muscle. The skeletal system, bones and joints. Bones are living tissue. We think of bones as being just structural elements, but they are living tissue, constantly being replaced as the various substructures, including the osteocytes, the bone cells, wear out, age, and are replaced. The bone tissue, there's also a lot of cartilage, especially as cushions. There is connective tissue, and of course, they produce blood cells, and protect softer tissues and organs. Bones basically are part of the superstructure of the body, or the basic structural element that gives the body what rigidity it has. There are 206 bones, classified into long, short, flat, irregular, or round. A precursor cell called an osteoblast produces the bone matrix. and that bone matrix contains the osteocytes, which are the mature bone cells. They osteoclasts are another set of cells that are involved in reabsorption of calcium and phosphorus and other elements from other minerals from the bone, and then replacing those with new. This constant regeneration of the bone is what gives it the ability to withstand stress, and that the lack of that regeneration, that constant regeneration, leads to brittle conditions in the bones. The adult skeleton has two major portions. The axial skeleton is the skull, the middle ear bones, the hyoid bone, which is the back of the throat, the vertebral column, and the thoracic cage. It totals about 80 of the 206. The appendicular or limb portion of the skeleton contains the pectoral girdle, which is our shoulder structure, upper and lower limbs, and then the pelvic girdle, and that's the other 126 bones. So here is a picture of the skeleton showing, again, bones. You've seen this in your A&P classes, I know, with Karen and Nate. So this all ought to be fairly clear to you. Depending on the kind of practice you're in, you'll have to know a lot more detail about certain areas, but in all practices, you need to know about the structure of the skeletal system. Joints are covered with cartilage, and they're classified on their degree of movement. The synarthroses do not allow movement, and these are things like the sutures in the skull bones, and other places like the gomphoses, where the wage tooth fits in its pocket and is held in place. So we have the next one is amphiarthroses. These allow for a little bit of movement. This things like the symphysis pubis, which expands slightly to increase the size of the birth canal to allow delivery, and the diarthroses, which allow free movement, and are also known as the synovial joints. The knee, the shoulder, all of these allow free movement, and sometimes in only one plane of direction. The knee can bend forward or backward, but it can't bend to the side, for instance. These joints, the interior, the capsule of the joint, the bursa, is lined. The surrounding, the capsule, also known as the bursa that surrounds joints, is lined with synovial fluid, and the membrane that lines them is the synovial membrane. Let's go to the muscular system quickly. There are over 600 muscles in the body. Some are very small. Some are much, much larger. They can attach skeletal muscles attached to the bones and joints by the connective tendons and ligaments, and smooth muscle as well here. Skeletal muscle is voluntary. In other words, we consciously control what it does. They are stimulated by nerve firing. A little electrical impulse comes from the nerve that actually acts on a protein to cause it to expand or contract, and then the muscle moves. Um, okay. And the muscle performing the movement is usually called a prime mover, sometimes also known as an agonist. Um, Muscles can oppose each other. Those that oppose an agonist are antagonists. And muscles, they can also assist each other. Remember, we talked about that in drug interactions last week. You have antagonists, which work against each other, and you have synergy, which helps. So we have a synergist. So we are using similar language here. This graphic you've seen probably in your A&P classes. Just outlines the major superficial muscles. Disorders of the musculoskeletal system, um, injury, arthritis, osteomyelitis, rheumatic fever and rheumatoid arthritis, gout, osteoporosis, osteomalacia and rickets, bursitis and tendonitis, fibromyalgia, cramps, atrophy, hypertrophy, dystrophy, and myasthenia gravis, to name a few. Obviously, traumatic skeletal injuries are accompanied by soft tissue injuries to muscles and tendon. These may include um, contusions, bruises, hematomas, and lacerations, cuts, and breaks. Sprains involve the supporting ligaments in a joint, and strains are stretches or partial tears of muscle or of the paired muscle tendon units that are part of our anatomy. Arthritis, again, is an inflammatory condition of a joint. It usually, when you have arthritis, you can usually expect it to affect many joints. Um, there are over 100 different types of arthritis, and about 10% of humanity has it. Um, we have no idea how to cure it, but we usually just go for pain relief. Osteoarthritis is caused by the breakdown of cartilage in one or more joints. It's also known as a degenerative joint disease. Um, and according to your text, nearly everyone over 75 has osteoarthritis to some degree, um, usually the knees and hips. Again, no cure. Treatment is designed to reduce inflammation while maintaining joint function. PT, physical therapy, nutrition, supportive care, analgesics, muscle relaxants, nonsteroidal anti-inflammatory drugs are often used in the treatment of osteoarthritis. Osteomyelitis is an infection of the bones, usually caused by our good old friend Staphylococcus aureus. It is characteristically it is an inflammation, localized heat, which is um, felt as just that. It's an elevated temperature just in the joint or just in a location, swelling, pain, tenderness, and so forth. Treatment is often comes with long-term antibiotics um, um, and increases in protein, vitamins, bed rest, and prevention as best we can of reinfection. Rheumatic fever is linked to a bacterial infection during childhood. This bacterium can eventually affect joints, causing what we call migratory polyarthritis, meaning that it will move from joint to joint. Rheumatoid arthritis is something that we see a lot in older women, although men can certainly have it as well. It's a systemic disease. It is felt to be it is an autoimmune disease, and this inflammation attacks connective tissues of small joints. Pain and deformity in the hands and feet are common. And treatment, we are looking at a number of things. Most people will take non-steroidal anti-inflammatories. They'll take steroids. They take a drug out of the family of disease-modifying anti-rheumatic drugs. Drugs like methotrexate can be used for severe cases. Immunosuppressants. Lately, we've been experimenting with tumor necrosis factor, which is a protein drug, and others. Gout is a condition in which uric acid is not properly metabolized, and then precipitates into usually into a joint. Gout can affect elbows. It is most commonly seen in the feet and toes of males. It can be intensely painful. There are lots of treatments, including dietary modifications that we suggest for gout patients. Excuse me. We have drugs like allopurinol that are very, very good at reducing the gout. These are part of the anti-hyperuricemic medication family. Osteoporosis is a condition in which there is a loss of normal bone density. This is why women are often urged to get a bone density test. It most primarily seen in postmenopausal women, but it can occur in any group related to some diseases and partially related to lifestyle. Lots of treatments. Most of them include trying to increase your dietary calcium, because the loss of bone density usually is marked by a reduction in the amount of calcium within the bones. This family here, known as the bisphosphonates, made a lot of headlines a few years ago as treatments, but they only work for a few years. Estrogen replacement therapy for postmenopausal women has been tried with variable success. Osteomalacia and rickets. Osteomalacia is often called softening of the bones, is characterized by the bones literally not properly being mineralized in that process I described of the bones constantly recycling calcium and recirculating calcium and pulling it out and laying it down. The problem in there is that if that's not an effective process, then we can have softened bones. This disease in children is called rickets. Can be linked to a number of different things. Sunlight, lack of sunlight, to renal issues, and to vitamin D absorption issues. And what we used to treat this is dietary calcium, vitamin D, calcitonin, and increased sun exposure. You'll note that in both osteoporosis and in osteomalacia, there is nothing said about exercise. Bones are supposed to be used, so getting out and moving is one of the better forms of exercise. This stimulates the remineralization of the bones and of that exchange of calcium in and out of the bone, the living bone. Bursitis is an inflammation of the fluid-filled sac that surrounds our joints, um, and provides a surface to smoothly to have where there's contact to make that smooth and pain-free. Um, Corticosteroid injections, um, looking at activity and avoiding the activities that cause problems, and nonsteroidal anti-inflammatories are commonly used. Tendinitis is an inflammation of the tendons. Common example is tennis elbow, because of the overuse of the joint. Um, a lot of things can be done for it. Um, they mentioned surgery. Surgery should always be a last resort. Surgery on joints is is difficult and often not very successful. Fibromyalgia is a chronic condition that affects muscles, tendons, joints throughout the body. It is painful, and people will experience pain doing things like so much as raising an arm, or getting out of bed, or doing anything that normally wouldn't cause the slightest bit of pain. Um, there are no good treatments. It appears to have a relationship to stress and depression and so forth. So there are lots of ideas, but it is again, it's an individual kind of thing. Every person that has it in a different way. Cramps are painful, spastic muscle contractions. Virtually everyone has cramps now and again. They are not necessarily caused by this list here, connective tissue inflammation, lactic acid, or drugs, although they can be. The treatments include stretches, massage is a good one, heat, drink lots of fluids, make sure that your electrolytes are well balanced. Extreme cases may involve muscle relaxants and even the use of botulinum toxin, Botox, for treatment. Um, One of the things that many elderly do, many people do, for especially for leg cramps at night, since that's a problem that a number of people have, is they will drink tonic water. Um, Tonic water is a mixer that's often uh, um, seen paired with gin or vodka, but tonic water by itself contains quinine, which is a mild muscle relaxant, and is a very and works pretty well for many people for reducing nighttime cramps. Atrophy is a decrease in muscle mass that may occur from injury or lack of physical activity, nerve injury, really, since the nerves supply the signal that makes muscles work. This can be a more serious cause, it can be um, um, very difficult to treat. Um, Exercise, and things like water aerobics are good. Physical therapy and so forth are done. Hypertrophy is the opposite of atrophy. Atrophy is the wasting away. Hypertrophy is an increase in size. Um, um, this is linked to muscle exercise, and you can see this when people decide to bulk up by going to the gym and working out. Muscle cells can increase in size but not number, so the cells themselves actually get bigger. We don't add muscle cells. Muscular dystrophy is an inherited disease, usually of males, and there is no cure. Um, we're not even sure really how it's caused. The most common form is called Duchenne muscular dystrophy, and begins early in life, and ultimately results in the patient being um, um, not mobile, being not being able to move around. Treatments can be used, including some drugs, but they're generally not very successful. Myasthenia gravis is another autoimmune disease that begins in the face and mostly affects women, causes extreme weakness and fatigue, and treatments can be uh, based on other issues. We can have treatments restrict activity, use of certain drugs called anticholinesterases. Um, if there is if the cause or if it's related to a thymus gland tumor, then we can remove the thymus gland, and sometimes that helps. Um, Various medications include the muscle relaxants, antipyretics, in other words, fever reducers, anti-inflammatory drugs, skeletal muscle relaxants, work by blocking the nerve impulses through by depressing the activity of specific neurons. They're called neuromuscular blocking agents. For painful conditions, skeletal muscle relaxants can be used. These are some of the spasmolytics or antispasmodics, and you can find lists of those. Analgesics, antipyretics, and anti-inflammatories can be used. Some of them can be relieved. Where sometimes the pain requires opioids, but others can get along with non-opioid effects. Okay, and I'm going to take another short break, which you won't see because I'm going to pause the recording before moving on to the next chapter. Okay, chapter 14, we're going to go to the nervous system. This is related directly to your discussion of this week, looking at nervous system drugs. So let's talk about that. The nervous system is let's see. Okay, is the neurons of the brain, spinal cord, and the nerve fibers that all connect to carry electrical impulses for control and regulation of body activities. These can go to muscles, they can go to other tissues, they can, the voluntary muscles, the involuntary system as well. All of these are controlled by nerve impulses. Okay, and there are two sections: the central nervous system and the peripheral nervous system. This graphic here will give you some idea as to how the basic trunk nerves are spread, coming out of the brain, going down the spinal cord, and then branching off the spinal cord and going down the limbs. The CNS is located in the brain and the spinal cavity. And that central system is basically the control function for the body. Takes inference from the system, receives information from within the brain and from the peripheral nervous system, and it sends instructions to the body by the various divisions of the peripheral system. The brain consists of a number of parts. The cerebellum, which is the largest piece, it has two hemispheres that are connected by a structure called the corpus callosum. The diencephalon contains the thalamus, which relays incoming impulses, and the hypothalamus, which maintains homeostasis, meaning keeps things in balance. The brain also has a brain stem that consists of the midbrain, the pons, the medulla oblongata, and the medulla is the major control center for blood pressure, heart rate, breathing, and digestion. These are all parts of the autonomic or the autonomic system, i.e. the part that is not voluntary. The cerebellum coordinates the skeletal muscle movements from those two hemispheres. This graphic shows us a cross section. We have this. This is one hemisphere of the cerebellum. We have the thalamus and the hypothalamus structures here that are part of the diencephalon. We have the midbrain, the cerebellum, the medulla oblongata, and and the midbrain and the pons. These are all part of the brain stem structure. The peripheral system is outside the CNS. In other words, it's not part of the brain or the spinal column. Consists of 12 pairs of cranial and 31 pairs of spinal nerves, which branch to all parts of the body. And it's subdivided into the autonomic and the somatic nervous system. So we have this sort of flow chart, this organization, this organizational hierarchy chart. The nervous system is divided into the CNS and the peripheral. CNS is the brain and spinal column. We have the peripheral system is composed of sensory nerves, motor nerves, and mixed. In other words, those that respond to both types of stimula. The motor nerves are divided into voluntary and involuntary. And then we have further division of the involuntary system into sympathetic, which is also known as the adrenergic, and the parasympathetic or cholinergic arms of the involuntary system. That simple structural diagram is a good thing to study and learn. Cranial nerves can be a lot of different things. This graphic shows us where we have olfactory nerves, we have optic, we have the trigeminal nerve, we have the acoustic nerves, the vagus, accessory nerves, the hypoglossal, the glossopharyngeal, which, and these graphics show us what part of the body are being controlled here. The vagus goes down into all of the central organs. The acoustic obviously is the ear. The trigeminal is the facial nerves. Optic and olfactory obviously are the eye and the nose. And then we have separately the oculomotor system and the trochlear and abducens, which control movement of the eyeball. The glossopharyngeal involves different deeper facial muscles, and the hypoglossal moves down into the gut, and then the accessory controls the muscles that control the movement of the head. The autonomic system, we talked about that. We have the sympathetic, which responds to stress and emergency, and the parasympathetic, which is the most active under ordinary conditions. The somatic system is associated with the voluntary control, muscles, fibers, and motor neurons that supply the skeletal muscles. It is under voluntary control, but many of these muscle activities are used in balance and posture are not generally under conscious control. Then we have nerve cells. Neuron is the basic cell of the nervous system, carrying nerve impulses between body parts. It has a cell body as well as dendrites, which are little finger-like extrusions that are receptors carrying information to the cell body, and axons, which carry information away from the body. So here we have these dendrites, and we have an axon, and then the central cell, cell body, and the nucleus in the middle of it. And then that connects on to other tissues and cells. These all work through chemical messengers called neurotransmitters. At neuron junction, continuation of the messages is performed by acetylcholine and other neurotransmitters. Stimulates acetylcholine, or ACH, stimulates, while cholinesterate or cholinesterase inhibits the acetylcholine. Neurohormones are different kinds of these neurotransmitting chemicals. These include norepinephrine, epinephrine, dopamine, serotonin, and the endorphins. Disorders include, among many things, we have headaches, including migraines, meningitis, epilepsy, Parkinson's, Bell's palsy, and what we call tic douloureux, multiple sclerosis, and amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, Alzheimer's, schizophrenia, and bipolar diseases, major depressive disorders, anxiety disorders, and sleep disorders. Headache can be linked to a lot of things. There are different causes. A lot of things manifest themselves as located there. They can be acute, they can be chronic, and they can be in multiple places within the head. They can be linked to a variety of things, including, but not limited to, anxiety, hypertension. This whole list here on this slide is a partial list of what we can link them to. Diet can cause it, as well as other forms of stress that come from lifestyle issues and life issues. Treatment is based on the cause. There's one thing that they talk about, non-steroidal anti-inflammatories, tranks, muscle relaxants, warm baths, muscle massage. Sleep is another one that often is useful. Migraines are very severe, can incapacitate people. They are usually, they can be accompanied by nausea and vomiting. They can be visual symptoms, fatigue, anorexia, etc. Treatment will depend on the individual, but they can include quiet, dark rooms, analgesics, antiemetics for the nausea and vomiting, vasoconstrictors. All sorts of different drugs have been tried. We have a number of different drugs that are used now for the treatment of migraines, and they work for some people very well and not for others. Meningitis, which is an inflammation of the meninges, which are the the membranes that surround the brain and spinal cord. They can be caused, they can be virally caused, they can, or they can be bacterial. Um, Bacterial is less common but more severe. Um, Treatments for the bacterial include antibiotics, um, intravenous fluids, and other medications that will treat the associated symptoms like brain swelling, seizures, and shock. Viral meningitis can be severe. It can be temporary, or it can be chronic. Epilepsy is a chronic disorder where we have sudden electrical activity and causing seizures in the brain. Seizures can represent themselves all the way from what are known as absent seizures to where a person just suddenly isn't there. You're looking at them and they're sitting very still and they're very clearly not a part of this world. Um, and then then it can rain all the way to the severe tonic-clonic, where they're lying on the floor, spasming. And by the way, the idea of swallowing a tongue is not possible. That won't happen. There can be partial seizures that uh, arise in localized areas of the brain, or they can be generalized uh, seizures that are occurring in multiple places within the brain and may end up with loss of consciousness. Epilepsy is convulsions that differ from seizures and are actually involuntary muscle contraction. Um, the treatments can include anticonvulsants and other things that don't happen very often, like surgery. Parkinson's is a progressive degenerative disorder that affects the ability to to control our what we call our extrapyramidal activity, our arms and legs. Muscle tremor and rigidity, um, uh, bradykinesia, which is slow movement, posture issues, equilibrium, and things like pill rolling, rubbing thumb and forefinger together like you're rolling a pill between them. The part of the brain that's affected mostly is the substantia nigra, which causes a reduction in the amount of dopamine that are being secreted, which is one of the reasons that we use dopamine replacement to try and treat the disease. Um, we have a number of physical outward signs and that can be seen. Treatments involve a whole list of potential drugs that can be used, including antidepressants and this whole list down here on this particular slide that we're looking at the moment. ALS is a muscular atrophy and a progressive motor neuron destruction, meaning destruction of the nerves that control the muscles. Lou Gehrig was the most famous person who manifested this disease um, in the 20th century, or in the early part of the 20th century, and was a famous baseball player. And so he contracted this disease and gradually ended up dying. Many other people have had it. One of the most recent publicly known individuals with the disease was the physicist Stephen Hawking. Often, eventually, a ventilator is needed. Death usually occurs within 6 to 10 years, although Hawking lasted a lot longer than that, but then he had huge um, uh, group of people and resources behind keeping him alive. Um, there are no cures. It is there. Um, Bell's palsy occurs due to a paralysis of the facial nerve on one side, causing that um, side of the face to droop. It looks a lot like stroke, um, but it returns a lot faster than a stroke. Usually it returns fairly um, fairly quickly, but it can last for a long time. Um, and it's really critical to be able to recognize that it has occurred, and therefore get to treatment as quickly as possible. Um, and the treatment can include drugs and physical treatments like massage and heat applications, facial massages, etc. Tic douloureux is also known as um, trigeminal neuralgia. It's a pain from the area that's innervated by the trigeminal nerve. Remember, that covers the face. Pain may be felt in anywhere in the facial area, including eyes, lips, um, nose, tongue, and up near the ears. Treatments um, involve in cases where it can control, we can use analgesics, we can use certain CNS active drugs, um, avoiding tobacco products of any sort. And in very severe cases, surgery can be used to inhibit the nerve roots. MS, or multiple sclerosis, is caused, again, an incurable disease that is caused by loss of the myelin sheath around the nerves. The myelin sheath is used as a kind of cushion because you have a nerve, and if it didn't have something to protect it from the surrounding tissues, every time you so much as moved, you would hurt like crazy. So the lesions cause this myelin sheath to be eroded away and stiffened, um, and reducing conduction and causing muscle weakness. Um, Again, there are some drugs that are being used to treat, but there is nothing that cures. Alzheimer's, also known as senile disease complexes, um, most common in people older than 65. It's uh, it is a disease under a lot of study at the moment. Um, there are drugs that can be used to ameliorate the symptoms. There is no cure. Um, and it is a progressive atrophy of and deposition of plaques within the brain, causing problems there. Most It is the most common dementia, and it appears to be genetically linked. Short-term memory failure, impaired thinking, inability to learn or reason, confusion, and personality changes are very common. Difficult to accurately diagnose. People that have the disease are often very, very um, good at um, um, at hiding it, at disguising it. Treatments are mainly supportive, but again, we don't have anything that can cure it, but it is an object of a lot of research. Schizophrenia is a very severe mental illness characterized by disorganized thinking, hallucinations, poor judgment, withdrawal, and a distortion of reality compared to the rest of us. There may be a genetic issue involved, but but it causes physical changes in the brain mass. And there is as opposed to um, Parkinson's disease, where we have dopamine suppression. This is characterized by excessive dopamine secretion and decreases in blood flow to the front part of the brain. Late adolescence or early adulthood is commonly the onset of schizophrenia. There are a number of drugs that can be used, um, and psychotherapy and family counseling are needed. Dealing with schizophrenia as a family member can be very, very stressful. There are a number of drugs. We have a list here. There are others as well. Bipolar disorder used to be what we called manic depression, characterized by uh, periodic swings to extreme mania or excitation, and then going into a depressive phase. There are short period and long period bipolars. Some people will cycle on a very quick cycle. It can be as little as a few minutes. I've seen that. Or it can be, you can go for weeks or even months in one phase and then go to the other. Um, Treatments, we have various drugs that we use, um, and we try to treat it. Again, it's a matter of investigating with each patient what they are going to respond to. Um, this is a disease that is characterized by patients stopping taking the drugs. They really like the highs of the manic phase a lot, and um, and so they'll stop taking the drug even though they don't like the lows of the depressive phase. What the drugs do is they dampen them both. You get less high and you get less low, um, and so this is a problem. Patient compliance is a problem. Major depressive disorder is a mood disorder, which is characterized by one or more major depressive episodes. Major depression is a chemical deficit, so we treatments include psychotherapy and then using antidepressant drugs of a variety of type, one after the other, ultimately going to electroconvulsive therapy for very, very severe. One of the things that I believe is that um, the first treatment should always be psychotherapy, and then continued treatment with drugs should be with concomitant psychotherapy as well. Anxiety is not at all um, uncommon. It's usually temporary, but it can be chronic. Chronic anxiety is very difficult. Um, this is one of the most common, if not the most common, psychiatric illness in the U.S. We have a number of drugs as well as psychotherapy that can treat them. These are generally, all these drugs for all these conditions are long term. Generalized anxiety is a chronic condition, uncontrolled, um, and it is accompanied by depression or often another psychiatric disorder. These kinds of things, this anxiety that goes on for 6 months or longer, is really what we call generalized anxiety. Panic symptoms peak recurrent, these panic attacks, they usually peak quickly, 10 minutes or so. Trembling, shortness of breath, um, chest tightness, sweating, nausea, fast heartbeat. Panic attacks often are um, are often mistaken for the onset of a heart attack. OCD is another common issue. This can be a disabling condition, and it's um, characterized by uncontrollable obsessions. These are recurrent and persistent impulses, or by compulsions, which are sort of ritualized behavior that are a part of their response to the obsessive part. Social anxiety, a common disorder, which is an irrational fear of being watched by others. And this has a few common symptoms. Um, it is a common anxiety disorder, and usually starts in adolescence if we don't deal with it, and there needs to be, again, psychological counseling that goes along with it. It can continue. PTSD has gotten a lot of press lately. It is a reaction to a traumatic event, which brings on a reaction of fear, of helplessness, horror, etc. Treatments include various forms of counseling and various drugs. And the counseling, we're just learning how widespread PTSD is. Sleep disorders are not uncommon at all. It's the inability to sleep. Insomnia is the inability to sleep or stay asleep. There can be many causes, emotional, physical, or drugs. Treatment usually involves trying to remove the causes and reduce the stress. Regular sleep schedules are a help. Activity during the day, avoidance of stimulants, and looking to find ways to induce reaction or relaxation. This is a good list of medications that are used in the CNS. And we talked about them all: sedatives, hypnotics, anti-anxiety drugs. Many of these are the same thing. Anticonvulsants, Parkinson's drugs, antidepressants, narcotic analgesics to relieve pain symptoms. Sedatives are used for a number of things. Sedation is characterized by decreased anxiety, decreased motor activity, and decreased, unfortunately, mental acuity. Anticonvulsants, these are some of the more common. Anti-Parkinson's, you can look in the text. Antipsychotics, there are a number of these, which are used to treat the symptoms of psychotic events like schizophrenia. So some of the conventional drugs are we don't know how they work, and this is a case common in medicine. Atypical agents, the conventional agents appear to block dopamine. Atypical agents also seem to block serotonin. The narcotics, or the opioids, have morphine-like activity to reduce pain. Unfortunately, they also cause tolerance and physical dependence. Anesthesia is a process of reducing the ability of the body to feel sensations. We have general anesthetics and we have local anesthetics like lidocaine, which will produce a loss of sensation in local areas. but general anesthetics are what we use for major surgeries to reduce sensation throughout the body. So that's chapter 14. And I'm going to pause a little bit and take a voice break before coming back and talking about some other issues. Okay, Kat, I've talked a lot for the last couple hours. So what I will do is we will finish with chapter 15, which is sight and hearing, and chapter 18, which is the lymphatic system, on Wednesday. And we will do our in-class activity and give you a chance to work on other things as well. And I'll tell you what the in-class activity is on Wednesday. So meanwhile, let's go ahead and get started on the discussion. Take a look at your at the information about the CNS and its drugs and why they're so addictive. Have we frozen? Okay, good. I was afraid we'd frozen up there for a minute. So look at your discussion. I've got my own initial posting on that. So and then let's go ahead and get started on the week 2 assignment. Work on some of those workbooks. And get started on that, get your answers set up. And then you can do the assessment afterwards if you wish. So go ahead and get started. Watch this. Let me know that you've watched it. The code word for this week is Singapore, Singapore. So go ahead and send that. And I hope you can get some rest. I'm assuming the fact that you're not online yet means that you were too tired, and that's fine. You did say that would happen. So we'll cut this recording off here, and you'll have to get to work on some of this material, and I will see you on Wednesday night.